Hey guys, how you doing? Frankenthal, G&G Productions, bringing you another protocol video. Today I'm reading from directly from the Lee County Common Treatment Guidelines book, revised in 2021, which is the latest version we're using out there. And today I'm going to put it up on the screen here. I'm going to read the spinal motion restriction protocol. And this protocol tells us when to use and when not to use C-collars following an accident or an incident. And I'm just going to go ahead and dive right into it. So the goal is to provide evidence-based and reason logic core principles for spinal motion restriction in patients that have sustained injury or trauma. Rigid spine devices are extrication transfer tools, not a therapeutic intervention. So they're just tools to transfer a patient from the vehicle or the area of injury to the stretcher, and they're not used to make the patients better, if you will. And there's a couple pearls at the top here. The first pearl, blunt force trauma alert, require a rigid spine board device. So if they sustain blunt trauma, and because of the blunt trauma, they are now a trauma alert criteria, these patients require a rigid spine device. That's your first pearl. Our second pearl, scoop stretchers are preferential to long spine boards. It doesn't say it shall be or will be used instead of a long spine board. It just says that they're preferential. They still have a lot of benefits over a long spine board, ease of putting on, ease of taking off, on and on and on. So we're gonna go for a scoop stretcher first rather than the long spine board, but we still can use a long spine board. Third pearl, penetrating trauma alerts do not benefit from or require a rigid spine device. Back in the day, penetrating trauma from a bullet, for example, without an exit wound, these patients would be put on a C-collar and a rigid device because the theory was that we didn't know where the bullet was, that it might have been lodged along the spine, and any movement might have worsened the patient and or paralyzed the patient. So that's what we used to do, but now it's saying we don't do that anymore. And the fourth pearl, precautionary spinal mobilization, offers no patent value or no patient value and may result in iatrogenic injury, meaning that it has no value for putting them on the spine board, and it may cause further injury, like studies have shown. And when we put C-collars on or we don't put C-collars on, that can be determined at the EMT level because it says right here, basic life support actions. It does not have to be a paramedic. It can be an EMT that determines whether a C-collar goes on or does not go on. So the first block we have here on the left, I'll put it up on the screen so you can see. Did the patient sustain blunt force injury? If not, then no spinal motion restriction required. If the patient did sustain blunt force injury, was there, because of the blunt force trauma, was the patient a trauma alert? If yes, they get a collar. If not, they go down to the first block on the scale here. If they are not a trauma alert and sustain blunt force trauma, do they have any cervical neck pain, tenderness, or anatomical abnormalities? Any softness, tenderness, rigidity, any pain on palpation, anything like that to the neck, they're gonna get a C-collar. Next one down, do they have an altered mental state or an altered mental status following a blunt force trauma? So they had a blunt force trauma, steering wheel to the chest. They weren't a trauma alert, but now you ask them their name and they say Jello, right? These patients require a C-collar. Next on the road, if the next one down there, if the patient is on drugs or alcohol, remember alcohol is a central nervous system depressant. It depresses your nerve sensations. So if these patients were in pain, they were not able to tell you. So remember the alcohol and or drugs is masking the pain that otherwise they would be complaining to you about. So let's put these patients on C-collars. Next one down, any distracting injury or injury to circumstance. Patient was in a front-end collision, hit the steering wheel, was not a trauma alert, but now has a femur fracture. Those patients get a C-collar because it took significant force to break that femur. There might have been significant force to get a head or neck injury. The next one, last one down here, any patients under 5 or over 65 with maxillofacial trauma or scalp injury, these patients will get a C-collar. So you get a 67-year-old with a broken socket, orbital socket, who was involved in a front-end collision, took a steering wheel to the chest, but it's not a trauma alert. This patient gets a C-collar. Same thing if it was under 5 years old, they get a C-collar as well. And at the bottom down here, if you're still not sure who does or who doesn't get a C-collar, as always, they tell you right at the bottom of the protocol, get a hold of medical control. And if you have any questions or concerns, your medical control doctor will let you know to put a C-collar on or not. They're usually always going to tell you to put a C-collar on because they're going to side on the air of caution. And until they get a CT, MRI, or X-ray, they're not going to be able to tell if there's any injury or not. So that's about it, guys. It's a short one, but it's filled with a lot of information. At the very top, we have 4 pearls right off the way, and we have 1, 2, 3, 4, 5 instances where we need to determine if the patient gets a C-collar or not. Let me know down below if you have any questions, comments, or concerns, guys. Thanks for watching. Please hit the like and subscribe button. And again, thanks for watching. For Gonzalez, G&G Productions. We'll see you on the next one.